Good afternoon, and thank you everyone for coming to the first inaugural abstract session of the conference. I would like to thank Dr. Paul Underwood for helping moderate this and Dr. Sandesh Day for organizing. So without further ado, we're going to start with our first presentation. This is Does Disease Stage Modifying Treatment Benefit in ATTR Cardiomyopathy? And we have PGY1 from Banadel Lab, Poonam, presenting her poster today. So please come up. All yours.
Thank you. So good afternoon, everyone. Today, we are addressing a critical question in management of amyloid cardiomyopathy. So does the timing of intervention dictate the ceiling of success? So while the disease-modifying therapy does have revolutionized the ATT cardiomyopathy care, the progressive nature of the disease suggests that a window of opportunity may be actually narrower than previously thought. So today we are going to look into the stage evidence-based synthesis, combining all the randomized control trials, the registries, and the real-world data to evaluate how this disease stage modifies the treatment benefit. Next. Okay, to understand why timing matters, we must first look at the pathophysiology. So ATTR-CM is characterized by progressive and largely irreversible depositions of amyloid fibrils in the myocardium. Currently, disease-modifying therapies work primarily through TTR stabilizations or through suppressions to halt the further progressions. So as you can see in the diagram, the early stage maintains the thin wall of the healthy heart. However, as the disease progresses, the window begins to close. So once the heavy deposition is established, the therapy may stabilize the heart, but it does so on a damaged heart. So this leads to a central hypothesis: does initiating therapy at advanced stage limit the potential cardiovascular benefit? So to answer this question, we integrated the data from 3 distinct sources to ensure there's a robust clinical conclusion. So first, we conducted an interaction meta-analysis of randomized control trials, specifically looking at the NYHA functional classes. Secondly, we assessed the directional consistency across all randomized trials for stabilizers and RNA silencing agents. And finally, we incorporate a real-world context using the THIOS registry, the US Medicare claims, to see if these trends are held outside the controlled trial environment. Okay, so the randomized data provided a striking answer. So in the ATTR ACT trial, the tafamidis actually significantly reduced the cardiovascular hospitalization for patients in NYHA class 1 and class 2 with a rate ratio of 0.46. However, look at the red bar for the NYHA class 3. So the benefit was not just reduced, it was actually attenuated with a rate ratio of 1.48. So this represents a marked interaction of ratio of effects of approximately 0.31 favoring early stage initiations. So we also observed a similar attenuation of benefit in the ATTR attribute cardiomyopathy trial. So across the board, no randomized trial has ever demonstrated the preferential benefits for starting the therapy at NYHA class 3. So this is the data from the real world that reinforces these findings. So this is from THIOS registry. Patients starting at NYHA class 3 experience substantially higher annual cardiovascular hospitalization rates and more rapid disease progressions compared to those starting earlier. Similarly, the Medicare claim data showed that while therapy is effective, the ability to reduce heart failure hospitalizations is significantly higher when started early in the disease course. So that brings to our key takeaway point. So efficacy is time dependent. So we must view the treatment of ATTR cardiomyopathy as like a domino effect. So it starts with early treatment, then it leads to timely referrals, which results in prompt initiation. This sequence is a summary of primary driver of reducing the hospitalizations and preserving the cardiac functions. So in conclusions, our synthesis of RCTs, the registries, and the claims data all point towards one robust conclusion, that the cardiovascular benefit of disease-modifying therapy is greatest when it's initiated early on. So to save the myocardium, we must act before the therapeutic window closes. Thank you.
Are there any questions? Yeah.
Thank you for that wonderful presentation. I think it really, you're speaking to the choir concerning the need for early diagnosis. Just in looking at the data, do you have an idea of the number of patients that were in those registries, or how many, what sample size do we have?
I actually don't have the number of data in the registries, but it's just something that was mentioned and we just concluded together. But this was something, the only registry that had like the ATTR-CM registered online.
No, it's fantastic because the data are very clear. Also, just have a question for you in terms of using NYHA classification as a way of staging people. Are there other perhaps more objective ways that one might want to stage people? I know that there are very limited markers available to understand how much amyloid is actually in a person, but do you think that there would be any benefit of knowing more objectively than looking for subjective tests such as New York Heart Association classification?
Yes. Besides the NYHA class, I think there was a trial, the ACT trial. So they looked into the functional classifications while segregating this data, and I think they used the Kansas City cardiomyopathy questionnaires, and even 6-minute walk test was used for the interpretation, not just on structural level, but also on the functional levels. So we can also look into those aspects too while treating a patient.
Great. Yeah. Thank you.
Thank you.
Are there other questions from the audience? Thank you very much. Thank you.